Juan, doctor Justo. Hola, hi, Dr. Misrai. Be very welcome to our house. Thank you very much for coming. It's an honor hosting you, such a big professional and expert with us. Dr. Justo is the guy who is the doctor who is doing in our team, AquaBeam. So just explain us the procedure and let's begin with the patient. We will be changing and moving from your OR to the other one because Dr. Bianco is doing his procedure. So please go ahead and be very welcome. Thank you for coming.
Thank you. Firstly, thank you for the invitation. I'm very grateful to be here with you to demonstrate you an AquaBeam procedure. For those who don't know the AquaBeam procedure, it's a complete change in the paradigm. In other words, in fact, when you do a disobstruction surgery with TURP, enucleation, etc., you need to be skilled to train your hands to do the movements to be able to operate. For this procedure, for AquaBeam procedure, it's a complete change in the paradigm. So you use your hands to do the settings. Okay, so you will use your hands to manipulate the keyboards, the mouse, and the rectal probe to do the settings. So it's completely different. So let's first talking about the patient. So the patient is a 56 years old patient in chronic retention. So he had an indwelling catheter for time, refractory to medications. And the prostate size has been checked with the MRI because the PSA was 8. So the MRI did not show any abnormalities. And the prostate size is 100 without median lobe. So it's a good thing from a technical point of view. So let me show you the instruments. So we have a console here. We have a keyboard with a mouse. The rectal probe here. The rectal probe will give some feedback, some information to the system to do the settings and to plan the area to be resected, ablated. We have a camera, of course, with a system to visualize inside. So the prostate will be squeezed between the rectal probe and the handpiece. The handpiece is here. So this is a disposable single-use handpiece here, connected with the irrigation aspiration tube. Inside we have a small scope, 0-degree length, to see the view inside, endoscopic view. And we fixed the disposable and the handpiece and the rectal probe to arms, respectively. So we have two arms between on each side of the table, and we will connect the handpiece to the arm on the right side. So we have first to prime the system. So we already primed the system to carry on the procedure. Maybe we can see. Okay, the anatomy of the prostate. Okay, so we have a sagittal view here. The sagittal view of the prostate, and the rectal probe is down, of course, and we see the capsule and the rectal wall just down to the prostate. And the bladder, we cannot see clearly the bladder, but we will see that. So first is to introduce. We have some gels. Yeah, good. So the patient is in dorsolitotomy position. And we will introduce the handpiece. Okay. I will progress in the urethra. Oh. Okay. Okay. So we see the verumontanum. So why did the patient choose aquablation? Because he would like to preserve ejaculation, antegrade ejaculation. So the verumontanum, we can see the verumontanum with endoscopic view. This is the sphincter. And the veru is here. So we check the veru endoscopically and with the ultrasound feedback. So we see the verumontanum on the screen, the left screen, with the ultrasound, and on the right screen with the scope. Now I go through the urethra. Okay, I'm in the bladder, some small clothes, but and now I will attach the handpiece to the arm. Okay. Okay, that's fine. So we have the bladder neck here, and we need to check that the scope is parallel to the rectal probe. Okay, like that. Perfect. I think it's fine.
Hello, Vincent.
Yeah.
Hello, Vincent.
Hello.
How are you doing? Hello, Vincent.
Hello.
I'm Dr. Perez Carral. I have a little experience as well in AquaBeam in Hospital La Paz, and I think this step that you are performing perfectly and making a good alignment with the rectal probe is the key point to make a quick and easy procedure, don't you think?
Yeah.
It seems so easy, but I think is the key point for proper surgery, don't you think?
Yeah, I think. Can I have the chair? Yeah, all the procedure is relying, or not all, but biggest part of the procedure is relying on the probe, rectal probe placement, and the lubricant you put inside to have a very clear vision of the prostate. Because if you don't see anything, the machine will give you some wrong informations. So the settings could be impaired by the bad vision. So the bad ultrasound vision. That's why, in fact, for very small prostate between 30 and 40, it is as well difficult to see clearly the prostate shape and the verumontanum, not endoscopically, but with the ultrasound. That's why I select my patients above 40 cc, 40 grams. Okay, so now just have a look at the screen.
Para la gente de la sala, no sé si conocéis el AquaBeam, lo que es un poco la idea para que os situéis, ¿no? Y me va a permitir esta licencia. Lo que está haciendo ahora son unos pasos, un checklist, está muy automatizado y muy estandarizado, que veis a la derecha de la pantalla. Ha colocado un ecógrafo transrectal para tener en todo momento control visual de la morfología y las características de la próstata y del tejido que luego va a marcar para eliminar. Y lo que tiene arriba es en la pieza de mano, donde por un lado tienes una óptica que te va a permitir localizar el verumontanum para respetar ese tejido y el cuello de la vejiga y los límites donde va a trabajar. Y esa pieza es la que va a emitir un chorro de agua a presión, velocidad de la luz, frío, no es red zoom, es frío, que corta. Es un poco la tecnología que usan los ingenieros hoy en día para cortar piezas, en vez del láser que dispersa calor y bueno, que generaría algunos de... Esto lo que hace es, una vez que lo planifique, lo vais a ver, destruir ese tejido que ha marcado dentro, es un proceso semi-robotizado, y una vez que lo marque, lo hace en un tiempo muy rápido. Se parece más, estábamos comentando, Dr. Carral tiene mucha más experiencia que nosotros, a una resección que a una enucleación o ablación, y luego podemos discutir un poco cuál es el paciente ideal, las complicaciones, que seguramente Vincent nos lo va a comentar. Entonces, estos pasos son muy importantes porque aquí el paciente tiene que estar quieto, como cuando vas a hacer una biopsia de fusión, porque una vez que empiece el procedimiento, ya no hay opción de rectificar. Si ahora se despertase el paciente o se mueve, le cambia toda la planificación. Y esto es lo que al principio lleva tiempo y una vez que luego ya lo has hecho, realmente es un proceso muy estandarizado que te va marcando el guión y que tiene sus trucos, por supuesto, pero que es muy interesante.
I don't understand. Okay, so two very important things, steps right now is to check the depth of the resection of the prostate. So the water jet is limited to 24.3 millimeters. Okay, so it won't be able to go beyond 24.3. So you need to check the depth between the two lines. One is clearly marked by the horizontal line in green, and the second is here. I can grab, I can grab it here. So I will measure the depth of the prostate on the sagittal view. So you see 30 millimeters. So I need to compress a little bit more, to squeeze a little bit more the prostate, but not too much, because we don't want to. We need to fear about rectal perforation. Honestly, it never happened to me after more than 80 cases, but I know that some could fear about that. I always, for me. And there are some three cases reported in the literature in the World Journal of Urology about rectal perforation. So we need to respect the depth of 24.3. Okay, so this is the first step, and now the second step. So we compress a little bit more first. Okay, maybe like that. So, okay. Oh. So we'll measure again.
Which is your best patient to be treated? The one that wants to preserve ejaculation or the one that is taking anticoagulants?
I don't offer this procedure for a patient under oral anticoagulants, just because there are some reports that evaluated the erectile function when you are taking some oral anticoagulants. It means that you have some heart problem, and erectile dysfunction is a window on the heart and vice versa. So preserving antegrade ejaculation in patients that don't have EF5 more than 20, it's maybe not relevant. So the perfect patient, maybe this kind of patient, finally, because even if the prostate is big, 100, when we compress the prostate, the length of the prostate won't increase a lot. The issue is that the resection length is limited to 7 centimeters from the bladder neck to the apex of the prostate. The engine, the scope is able, the nose is able to move from 0 to 7 centimeters back. Okay.
Do you have any limit of size or you said, and I totally agree with you, that the prostate below 45 or 40 cc's are very challenging to treat with this, and it's quite difficult to do it. But do you have any limit in
superior limit, superior above an above limit? 150, I think. More than 150.
150.
It's a difficult case, and
even with the compression, it's going to take a while.
And you have to do many passes. So we check the nose, the nozzle here. We are in the bladder neck. I need to focus a little bit more. Sorry.
Vincent,
Yeah.
this is Dr. Pereira. How do you deal this situation in special patients with a small prostate that you don't have space between the handpiece and the ultrasound probe? I think it's one of the limitations of this technique. You
Sorry,
have,
say it again.
how do you deal
Yeah.
with these patients with a small prostate when you have in the external part a conflict between the handpiece and the ultrasound
Yeah.
probe?
Yeah, it's difficult when the prostate
Sometimes,
is
sometimes it's really very close between.
yeah.
The,
When you squeeze the prostate, you mean that the handpiece and the rectal, the ultrasound probe are very close, and it's it's difficult. It's a small issue exactly. So in fact, we have we are limited for the compression in this kind of case because there is a conflict between the two pieces. I don't have any particular tips and tricks for that. Just say that I limit the compression. But if I limit the compression, in fact, the tissue will be smooth and not stronger than compared if you squeeze a lot. So the efficiency of the ablation won't be really good.
No optimal procedure, yeah. Probably that's the reason because we have choose this technique not for prostate less than 40 or
So
30 cc's.
we can see here. You see I retract the scope. I retract the scope here.
Show us how you have it because we have to move to the other OR. Just a second, because Dr. Bianco is ready to finish his treatment. So just show us the endoscopy, please. We would love it to see it.
Yeah, the sphincter is just back from the scope to the scope.
Yeah,
okay, just behind. I'm at the.
We can see the Veru.
Here, you see the sphincter. So the sphincter here is completely covered by the sheath. So there is no risk of damaging the sphincter with the jet, the water jet, the high pressure jet. So now we can quickly proceed to the next step. It's just an optimization of the image. So,
okay, meanwhile you are scheduling the simulation, we are moving to the other OR. Okay, vale. Dr. Misrai, welcome again. Please explain us everything. How are your settings?
So, aquablation is almost relying on exclusively relying on settings. So resection is automated. So it is a semi-autonomous procedure, depending on the settings you made just before. So we initiated the settings. So we need to align the handpiece and the probe with the ultrasound and the image of the vision, endoscopic vision, and we proceed to the settings to delimitate the area to resect with the high pressure water jet. So we started with a transversal view. So we are at mid prostate. You see the angle. You see the angle of the resection, 135 degrees. So the AquaBeam system is limited to 220 degrees. So in this case, we compressed the prostate, and we don't need to extend the angulation of the resection laterally because we don't want to create a capsular perforation. So you see the limitation of the prostate, the sides of the prostate, right and left, and we see the angle. The dot 3 and dot 4 are delimiting the angulation of the area to be ablated. And we have the maximum depth here, 24.3 millimeters. So we are far from the rectal wall. So we are safe here. We enable the median lobe resection here on the right part here, median lobe. So we can enable the resection of the median lobe. There is a small median lobe, in fact, in this case, for this patient. So we will proceed to the next step.
No, perfect.
So, what is very clever with this technology is that if you don't remember how to do it, there is some tutorials on the console, so you can click and then okay, how to proceed. You do that, you do this, and that's fine.
No, perfect planification. Very nice. I think the one important thing that we have to emphasize is that you are using the 100% of the power of the device, applying the energy to 24 millimeters, because maybe the people here in the hall they don't know how the energy of the water jet works in the prostate.
In fact, if you use 100%, you are more efficient than if you are at 60 or,
Exactly.
or 70.
Exactly.
So I was not aware about this fact when I started, but it's very important, as you said, as you mentioned, to emphasize that point.
Yeah. Because for the new people here, for the audience, the power of the device doesn't make the same effect in the tissue depending of the depth of the water jet. Probably in the vaporization of the tissue that is going to be completely eliminated in the first pass is only the third of that depth.
Completely agree.
Yeah, and that's why, for example, Chechu, before we were talking about with Vincent about the small prostates, because you are not able to do it at 100%. And the problem with the limitation with the device is that the area that Vincent is going to now to draw in the tissue is not going to be totally disappear after the procedure.
Yeah, we need several passes.
Yeah, exactly. The last third of the tissue is going to be preserved, and well, in that case, is going that is one thing that is better for the patient because it's safer, but you have to be aware of it.
Okay.
Ahí estáis viendo la línea de la óptica que está señalando dónde estaría el venum montanum. Veis que hay tres líneas, las dos del aparato y la que está más a la derecha con la óptica. Tú has visto dónde está el veru, porque uno de los éxitos de esta tecnología es que va a preservar el tejido paracuricular.
Yeah. Vincent,
te permite
you can start with the
the
drawing of the treatment. Yeah.
Perfect. So I will draw a virtual line following the line of the scope here. And now I will identify the nozzle where comes the water jet. So here it's relatively easy. Yeah. So I can press the arrows left or right to identify the nozzle, the water jet. Sometimes we have some issues with the identification of the nozzle because the water jet will hit directly the median lobe. So it's much more difficult.
Y ahora lo que está haciendo es identificando dónde sale el disparo, que tiene que ser por delante de donde empieza la próstata. Para pintar eso, que es donde va a hacer el tratamiento finalmente el dispositivo.
Estas próstatas, además, esta no tiene lóbulo medio, pero algunas tienen lóbulo medio, conviene empezar, un poquito más adelante.
Y ahora lo que va a hacer es pintar. ¿Dónde tiene que penetrar finalmente el chorro? Va a ir pintando dónde empieza.
We are seeing you in the screen, but we are doing a presentation here in downstairs because we are being too tight with the time. So please.
So it's almost done. So treatment starts. So the treatment will start here. Let's say virtually. Yeah, I put a dot here. One dot on the bladder neck. Oh, maybe a little bit more here. Okay. Oh. So you can put here at mid prostate, and the last part, let's say here. Okay. And now we have the planification zone. So it's really nice to see that. So the limitation is mentioned by the purple line here. This is the maximum depth. So now I can adjust. The rejection zone. So I can increase the bladder neck preservation if I want. I didn't mention the verumontanum.
Es una zona en la que se hace un corte en alas de mariposa. Solo va para un lado y solo va para el otro, no incide en la parte central.
Are you okay with the settings?
Para preservar la zona, el tejido que está alrededor del verumontanum y no alterar la eyaculación.
That's fine. Okay.
Luego cuando empiece ya será apretar el pedal.
Okay, and the area of preservation of the perimontanal area is here, mentioned here with the zone, the gray zone here. And you can extend. Of course, if you extend too much, the patient won't be able to pee because he was in retention previously. If you decrease too much, the patient will maybe have some ejaculation dysfunction. So my experience, it's okay, level 5 of evidence, follow the instruction of the suggestion of the technology. If when I changed the rare time I changed, I was disappointed.
Okay, Vincent.
Okay, so now
if you are happy with the planification, maybe you can start applying.
Okay.
Yeah. Confirm.
Okay. And then.
Claro.
Okay.
Sí, y luego se aplica mientras eso es. Ahora está presionando el pedal y gracias a eso se está aplicando. En cuanto tú ves que te estás yendo con el chorro o tienes algún problema, o aflojas o levantas el pedal y para inmediatamente la máquina. Y ahora lo que va a hacer es barrer toda la próstata durante esos 4 minutos. Y luego ya veremos, una vez que haya terminado, el efecto que ha tenido. Probablemente igual tiene que hacer otra pasada porque la próstata es grande, pero ya lo veremos.
El micrófono si no se te entiende. Bueno, well, now you are doing the procedure. Lo que él está haciendo ahora es que al apretar el pedal sale el chorro del agua. El tiempo que le queda es el que pone en la planificación, que son 3 minutos 30 y tantos segundos. Entonces va haciendo el chorro del agua desde el cuello hacia el veru, ¿vale? Vamos a dejar en la esquina arriba al doctor Misrai y vamos a poner, por favor, la presentación de la doctora González. Doctor Justo, Misrai, damos paso otra vez a vuestro quirófano. Hola, hello, can you hear us? Doctor Misrai, Vincent, Juan.
¿Podéis escucharnos?
Can you hear us?
Yes, we can hear you. So you have finished the AquaBeam procedure, and now you are doing a cystoscopy to check how is everything. So explain us, please, everything.
I will show you the inside view, endoscopic view. So I use a monopolar or bipolar loop.
No sé si podéis ver en la pantalla de la ecografía
the apical part with
el hueco que queda y el flujo cuando va
saliendo.
Yes, we can see the cavity you are having at the end of the procedure. That it's really good. It's really nice. We would like to see the endoscopy also to see how is the tissue inside.
Yeah, it's like a fluffy tissues. I used to spend 10 minutes, maybe sometimes a little bit more, to remove the fluffy tissue because it can obstruct the Foley catheter, and impair the irrigation. So we are in the bladder here. Okay. Oh, I'm not really familiar with passive resectoscope. I use active resectoscope usually. Anyway, so we are here at the level of the bladder neck. Some clots, we will remove the clots. So you see the cavity here. And if I see some bleeders, I will discuss about that in my presentation. I always coagulate. When we conducted the Francais water, which is I can use the loop here to coagulate. There is no, nothing happens. When we conducted the Francais water study, which was a simple observational study, prospective but observational study, we weren't allowed to do coagulation, so we systematically put the Foley catheter in traction to avoid.
See, Vincent, you systematically perform bipolar or bipolar coagulation? Not systematically.
Not systematically. If I see a small bleeder, I will do here, for example. Here.
So did you perform it or not?
Not systematically. When I see like that, if I see some active
or
bleeding,
it depends of the size or
yeah,
the prostate, maybe
the shape of the
above
prostate.
100 or 80.
The number of it doesn't work. It doesn't work. I don't know why. No.
We sleep better.
Okay.
We review the.
Well,
you want to change the.
Sí, nos está fallando un segundito. Si
So I
queréis
removed
seguir con Carmen.
this kind of tissue.
we can see that the cavity is really good and it is no bleeding. It's you have it really good at the end of the procedure. So congratulations. Thank you very much for coming and sharing your expertise with us.
Thank you. Thank you again.
AquaBeam is a very good option. We are using it in our hospital. We have done 40 cases of AquaBeam and we are really happy with it. So congratulations and vamos a dar un aplauso al doctor Misrai.
Thank you.
Y nuestro agradecimiento. Muchas gracias.